And so it's just, again, a plea for those colleagues out there to look at the study, look at the data, see if it applies to your patient that you have in front of you. And if it doesn't, then, don't apply it.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. I have with me Dr. Nijjer from the UK. And, what we've done traditionally in the past 4 seasons is that Dr. Nijjer has been gracious to come back on the show and talk to us about, the year that went by. He's picked for us trials which, he thinks are the most important, how we practice clinical cardiology, whether it's in the cath lab or whether it's in our outpatient clinics. So this episode, he's going to discuss the trials which will shape cardiology in 2023, and these were all presented in 2022. So with that introduction, by the way, no one needs to know about Dr. Sukh Nijjer. He's a world-renowned interventionist and a clinical cardiologist, and he practices in the UK and has an academic appointment at the Imperial College in London. So with that introduction, Sukh, welcome on the show, and thank you so much for doing this for us again.
Thank you so much, Ankur. Thank you for the kind invitation. It's always a pleasure to be back on Parallax, and I've enjoyed listening to your conversations with so many esteemed colleagues from the US and all over the world. I always feel I enjoy a lot from listening, learn a lot of information from colleagues, and I enjoy our conversation about these studies.
Yeah, no, likewise. I actually end up learning each time we have a conversation. So we're just going to dive right in. So I'm going to have you, start the conversation by talking to us about FLAVOUR, which was presented at the American College of Cardiology annual scientific sessions in 2022. And who better than you to talk to us about coronary physiology and physiology-guided PCI? So I'll let you talk to us about FLAVOUR.
Yeah, thanks, Ankur. So FLAVOUR is a study that's relevant for interventionalists, so perhaps less relevant for general cardiologists, but still important because so many of our patients end up having revascularization. And I show a little bit of my bias by talking first about this study because it's about coronary physiology, and this is something that I've spent a lot of time thinking about and publishing about. And so it was done by colleagues, Bon Kwon Koo, who's an established and really quite esteemed interventionalist from South Korea, and it was presented at ACC at the beginning of the year. And what they tried to show, or what they were aimed to do, was compare FFR-guided revascularization to image-guided revascularization in the form of intravascular imaging with IVUS. And non-interventionists may be aware that there's been an increasing controversy over which modality to use to guide our intervention into our stents. And in the majority of cases, for stable coronary disease, I think it's now well known and well accepted by most of us in the field that stable patients should be offered medical therapy for the majority of the time. And only if there is unacceptable symptoms, then should they be offered PCI. And then when you have a stable patient, you do an angiogram, we often find that there are multiple narrowings and multiple lesions in the vessels. We don't always know which lesion to target. And for a long time, we've used FFR, or fractional flow reserve, which is a pressure that's measured within the coronary artery using a pressure wire, and say, well, we're going to target this particular vessel versus, say, the LAD versus the circumflex, because this appears to be where the ischemia is most. And on the other side of that paradigm, people feel that we should be targeting plaque and the volume of plaque. And by using intravascular ultrasound, we can definitely see that. And this often leads to a little bit of confusion, because sometimes we see a lot of plaque in a vessel, but the vessel may not be physiologically significant, may not be causing ischemia. And there's always been a push and pull over which technology is better. And so that's what these colleagues try to assess. What they wanted to show was that the two technologies, they wanted to see if one was better than the other, or if they were non-inferior. They took around 800 or so patients in each arm, and they randomized them in an open label way. It's quite challenging to blind patients and operators about this kind of thing. It can be done. We've done it as part of the Orbiter study and defined PCI, but it's a little bit tricky. And what they showed was that there were similar events seen in both the fractional flow reserve group and in the FFR group. So whether you use a physiology parameter or whether you use an IVUS-guided approach, the outcomes were similar. There's a couple of things to talk about here. Lots of commentators and lots of people looking at this have taken this as a win for IVUS and said, well, that means that we don't have to use FFR, we can simply use IVUS, and we basically have a technology that leads to really good results. There's a few points here in regards to that, because in the IVUS arm, a lot more revascularization was performed and a lot more stents were performed, and yet there were no differences in any of the important outcomes. There were no differences in death. There were no differences in revascularization. And there were no differences in the satellite angina questionnaire. So it means that we were performing a lot more revascularization without a lot of difference in events. And so I would put it to the listeners and say, well, does that really mean that IVUS is superior rather than using fractional flow reserve? And so that is just something that I wanted to highlight to the listeners and say that whilst people have looked at this study and said, well, that means we don't need FFR anymore. I say, well, actually, is that really what this study is showing? It's showing that we get equivalent results with a lot less stents if you use an FFR approach. And our practice has always been to combine the two technologies together. Again, to use a pressure wire to indicate the PCI, and then use the IVUS to tell us how to perform the PCI, which means assessing the vessel size, making sure that our stents are right size, making sure the stents are well expanded. Because as always, once a stent goes in, the outcome is determined by that stent and the quality of the stenting. And we see that even in this study. If you look at the arm that got medical therapy, that is fractional flow reserve was negative, more than 0.8. These patients didn't have stents. They had an incredibly low event rate in this study, 5%. But if you look at those patients that then went on and had PCI, they had multiple factors of event rate higher. So around 11 to 12% rates of events in the PCI arm. So again, it shows that if you do PCI, it has to be well performed and it has to be optimized. And so that's my principal take home from this particular study.
Yeah, no, I agree with you, Sukh. And I think, my own practice, I think the decision to stenting is a physiology-based decision. And, optimizing PCI is, when I would deploy intracoronary imaging, either IVUS or OCT, mostly IVUS. The way I would think about more revascularization in the IVUS arm is, I think the old angiography-based ocular stenotic reflex of the interventionalist, and that is, the more plaque you see, the more you want to stent it.
Yeah, I think that's absolutely right, and that keeps being shown. We must be humble as interventionalists. The skills that we've gained over the years does serve our patients well, because we've learned from doing complex lesions, then that can then be tackled when patients are having non-ST elevation or ST elevation MI, and that certainly is of benefit. But we have to be humble in the fact that many of these patients don't need stents, and we can manage these patients for a period of time medically. And of course, if there are ongoing symptoms, then we can always do that, and that remains an option available for us. And then we should be really careful about making sure that we put the stents in the right place. And so a physiological approach using mapping, we did a couple of live case demonstrations at the most recent British Intervention Society meeting. And we showed that you can use mapping, physiological mapping within the vessel to show where the lesions are most important, and then guide your strategy through that. And if you do that, you limit the number of stents you put. Sometimes you end up putting more because it shows that you simply can't improve the vessel without covering the whole thing. And so actually, this whole thing about, I'm just going to sneak a little stent in here and get out, I think is really doing our patients a disservice. And it's unsurprising that so many of our PCI studies then come out negative. We should just be accepting of that, I think.
Yes, I agree with you. And I just have, I have one comment and then a couple follow-up questions for you here, Sukh. So one, the comment is that this is for the FLAVOUR study. These are non-left main lesions, right? These are not left main lesions.
So this is standard kind of coronary work, predominantly stable patients. Perhaps, although they talk about a lot of these patients being optimized, the actual total number of patients being optimized post-PCI is actually quite modest, with not great FFR values after the stents and not necessarily perfect MLAs at the end of PCI, even in the IVUS arm. So clearly more work could have been done, and that may have altered the results.
Yes, and then the two follow-up questions that I have for you is, one, would you extrapolate these results to, instantaneous wave-free ratio wire and also the diastolic hyperemia free ratio wire? So IFR and DFR is what I'm talking about. And I would, the assumption is yes. I would say yes.
Yeah, I would say almost certainly yes. The overlap between these technologies is sufficient for us to say that this is likely to hold true for those other parameters. There are some subtle differences that give advantages to the diastolic values in certain settings, perhaps less likely to be fooled in patients with left ventricular hypertrophy or those patients with diastolic dysfunction and diabetes, in which the microvascular isn't responsive to adenosine. So perhaps you perform a few more stents with one technology versus the other, but not enough to move the needle on a study like this. So I would expect the results to be the same.
Yes, and then for the for post PCI optimization, what MLA, minimal luminal area, do you target? I know the study was 5.5, but is that across a spectrum of each vessel? Or like the left main where you have the 5, 6, 7, 8 rule, you follow a certain rule in clinical practice? Or, in clinical practice, you also do post-PCI physiology, like you were discussing earlier?
Yeah, this is a very good question. So this portends to whether we believe these numbers mean anything at all. So this is the irony of how we get ourselves in knots in medical practice. So the various sizes in the coronary vessels have been validated. IVUS-based measures have been validated against fractional flow reserve and some limited outcome studies. So we get ourselves into a bit of a circle when we say we're going to aim for this particular number because it's better than FFR, but of course that number was validated against FFR. So my personal preference is to base it according to the distal reference zone. And we try and go for the slightly old-fashioned music criteria, which can be very difficult to hit. And this is a criteria that was used for Syntax 2, which had a complex cohort of patients with quite complex coronary disease. And you want to measure the distal reference size of your vessel, of your lumen, and you want to achieve at least 90% of that. And so your minimal stent area needs to be 90% of your distal reference. And so that can often be much larger than 5.5 millimeters. And certainly if I was in a proximal LAD and it was only just 5.5, then I would be unhappy with that. And then it tells you that you need to do more work. And the other components of it is to do with your edge of stent. Does it land in a lot of plaque? And when you've got plaque volume of more than 55%, then that is a predictor of long-term in-stent restenosis and early events. And so, again, it tells us that we need to take our stents a little bit longer and try and go as normal to normal as possible. Not always achievable. Some patients' disease is not treatable in a straightforward way, but if you can, then you certainly should go for it.
Yeah, and then I think just as a compliment to the investigators, this is just a closing remark for the FLAVOUR study before we move on to the next trial, is that the 29% of the patients were women, which is terrific. If you've looked at historical controls and trial enrollment among women, I think this was a win. And I think it sort of also mirrors clinical practice in that a third of these patients also had diabetes. So with that discussion, the next study that we're going to talk about, which, also is extremely relevant to clinical practice, whether you're a general cardiologist or an internist, is revived BCIS-2, which was presented at ESC, and published in the New England Journal. Extremely well done study, controversial, raised a lot of eyebrows. I'll have you talk about Revived with our listenership, Sukh.
Yeah, thank you, Ankur. So this is an incredibly complex study, and it's a huge round of applause to those organising, designing the study, and those recruiting patients into it. It's clearly a very difficult study to run because it was something that was conceived immediately after the Stitch study was published in around 2010. And so I can imagine that around 2011, when the final Stitch presentation came out at that point, that Professor Perera from St Thomas's Hospital in London was thinking of how he was going to answer this particular question. You'll remember that Stitch looked at patients with multivessel disease and poor LV function, so EFs of less than 35%, and offered them bypass surgery in an attempt to improve long-term outcomes and improve LV function. And in the first 2 to 5 years after Stitch, actually, there was increased hazard, as you would expect, because the patients were having major surgical procedure and there were events related to the surgery itself. But then if you look at the long-term follow-up of Stitch, what they showed were the outcomes improved and there was a switch in the curves such that those patients that had revascularization did better than those that did not. And that perhaps is what we would hope to see. And that's the central tenet of what we do in cardiology. And so it would inevitable to think, well, what if we were to replace bypass surgery with coronary intervention with PCI? And so they instituted this lovely study looking at patients with poor LV function, less than 35%, with known coronary disease. Almost all of these patients had 3-vessel disease. Around 90% of them had 3-vessel disease. And they included patients with left main stem. And the patients also had to have viability. And by that, the vast majority of the patients, around 70%, had cardiac MRI. And this is a UK study performed in hospitals around the country. And UK cardiac MRI access is actually surprisingly good. This is something that this country is actually very good at being able to deliver. And we've got a very strong cohort of consultant cardiologists in the imaging field. And so they were reporting on viability. And they then offered these patients either optimal medical therapy or revascularization. And what they found in this particular cohort of patients, and who the average age is around 70, mostly men, unfortunately, in this particular study, very few women, in fact, included, was that looking at their outcome at 8 years, so a long period of follow-up, that there was no difference at all whether the patients underwent revascularization or optimal medical therapy. And in fact, left ventricular function overall didn't really improve in the grand scheme of things when you look along the totality of the follow-up. And that there were very few secondary outcomes that were of benefit either, in terms of patients' Kansas City score, in terms of their well-being, and in terms of other aspects of MI, myocardial infarction, and these kind of parameters didn't really change dramatically across the totality of the study. And that has led to some commentators saying, well, that means that, it's a further death knell of PCI, that it essentially shows that in this so-called perfect setting that there was no value to performing PCI. And there are a couple of reasons to kind of push back against that. I think these studies are incredibly hard to do. In order to recruit these 700 patients or so, it essentially took 8 years to be able to do the study, which means that this is a highly selected cohort. There are many hospitals around the UK contributing to this study, many. And so the total number of patients recruited by individual operators is overall relatively low. And the time taken to recruit suggests that this is highly selected. And that might be because operators have their inherent bias. They feel that they should revascularize these patients, and therefore they don't want to randomize the patients where they actually think the most value is, which invariably means that those recruited into the study perhaps have slightly less value. Hard to say. Very hard to say. I know many of the people involved in this study, and I know that they're very diligent people who take performing studies very seriously. But also, there's a couple of other aspects of it that are a little bit unusual. These patients were all mostly angina-free. They did not have chest pain, and that was not a major driver to get into the study. This was revascularization for the sake of revascularization, not because of the presence of chest pain. So again, that's quite a little bit unusual, perhaps different from our practice, particularly now because things have changed over time. And also, we know that our practice changes a lot over that length of time. If you're doing a study which takes that length of time to do, then in that time, there's been a whole raft of changes simply in terms of medications available for heart failure management, medicines that have been proven to improve outcomes. And our style of revascularization has changed a lot. In the United Kingdom, it's just been published. Almost all of these cases now are done radially. The use of intravascular imaging is very, very high. And that's very true of data now. But perhaps if you look back at data from 2013 or 2014, that perhaps wasn't the case. So that does alter a little bit some of the results. So I'm a little cautious in how I interpret it. And also, I hesitate in some interpretation where people say, well, now that we have these results, it means that anytime I have a heart failure patient, I don't need to send them to the cath lab. I don't need to define their coronary anatomy. Let's express a little bit of caution there, because particularly in young patients with new onset heart failure, I think it's important to make sure that there is no left main stem or ostial LAD disease, because we do see patients who recover LV function when treated in that setting. And I think it is important because we know that there are other aspects of their care that are impacted on by knowing whether there is ischemia or coronary disease underlying this. So in terms of ICDs, we know that those patients with ischemic cardiomyopathies, poor LV function, do better than those with a cardiomyopathic process. So there's a few things to interpret in this study. I think it is very well done. I think we should applaud those involved in the study, because it is hard to run these, and it does help understand this field more. But I suppose at the same time, we mustn't completely change our practice without understanding the nuances that applies to all of these findings.
Yeah, no, excellent discussion, Sukh. There are a couple things that I want to tease out here, just for the listenership as well as for us as clinicians. And we see these patients not infrequently in our practice. I'm sure you would agree. The first question is, were these patients symptomatic at the time of diagnosis?
So it's a little tricky to fully understand when you go through the graphics and the paper published in New England. So the actual New York heart classification score for these patients is actually pretty low. Vast majority are 1 or 2 with breathlessness. And I think the number of patients who are actually having angina were also very little. So this is not a revascularization for angina study. This is active attempts at revascularizing patients with poor LV in the hope that by perhaps revascularizing an LAD or a right coronary artery, that subtends a viable territory that we can improve LV function. I would say that at the present, I haven't seen the data for the what happens at the time of intervention. So far, the data that I've seen, I know it's been presented in various conferences, but I haven't seen the papers on this yet, where the what happens in which territories and in terms of the quality of PCI that was performed and so on and so forth. And I think it is also worth noting that this was actually a fairly sick cohort of patients, because even at 2 years, the death rate is around, or the event rate is around 20%. And at 8 years, the event rate is in the kind of 40 to 60% rate, which is incredibly high. So that tells you that these patients are really quite sick, really, really quite sick. And so that also perhaps suggests that some of these patients were those who we were least likely to win in. And perhaps, for example, if it was a 50-year-old gentleman with recent onset LV dysfunction, then, that's something you can get an easy win in. Hard to say for certain. And perhaps in these patients who are on average around in their 70s, who've obviously had coronary disease for some time, have had LV dysfunction for some time, are we really going to make a dramatic difference in their outcome at that point? Hard to say.
Yes. And, I think I asked you about symptoms because, like I said, we see these patients not infrequently. But then, just to extrapolate the point that you made on a new diagnosis of LV systolic dysfunction in patients who get hospitalized. And, if your colleague is taking away the message that these patients now do not need an angiogram. That certainly is not the take-home message. I think it's important to define anatomy. And, like you said, it's a left main lesion, or if it's an osteo left anterior descending lesion, then these patients certainly would merit revascularization. Also, a lot of these patients do get hospitalized with acute decompensated heart failure. So that would certainly put them in New York Heart Association 3 or 4 class. So, these patients are different than what, were at least randomized in this trial.
Yeah, absolutely. I think it's hard to, whenever you're running a study like this, which requires multimodality imaging, requires the coronary disease, I understand, was fairly complicated, and therefore we needed a fair amount of work. They would have needed discussion in MDTs. All of this impacts on recruitment, getting patients in, performing the procedure, but that then also has some impact on generalizability. And certainly, my main concern with these studies is that it's just how they're interpreted. I think those in the academic circles are very intelligent and nuanced in the way they converse. It's just that so many colleagues only take away the headline, and the headline is, well, PCI fails in heart failure. And I think that leads to a change in behavior that may not be beneficial for your patient. And so it's just, again, a plea for those colleagues out there to look at the study, look at the data, see if it applies to your patient that you have in front of you. And if it doesn't, then, don't apply it.
Yeah, no, excellent point to wrap this discussion, which brings us to a third controversial study. I think fairly anticipated results. And, again, there was a lot of discussion on how the conclusion statements were handled in the New England Journal of Medicine paper. But, I'll have you discuss the results with us. And, this is protected TAVR. So this is use of a cerebral embolic protection device, in a standardized fashion. So all comers, in patients who are receiving transcatheter aortic valve replacement. And I'll have you talk about the study design and the results and what implications it has for clinical practice.
Yeah, absolutely. Okay, so I know this study is close to your heart. And this is, I'm not a TAVI operator or a TAVR operator. I'll declare that up front. My work has ended up being predominantly coronary work. And in our particular institution, we have a small cohort of TAVI operators who essentially exclusively do TAVI. They do a very large number. And we know that many of these patients who are put forward for TAVR have a elevated risk of stroke. And that stroke appears to be unpredictable, and lots of people have looked to see whether we can work out what strategies we can do to predict which patient is going to have a stroke at the time of TAVR placement. And there are lots of theories of why the stroke happens. In terms of when we fracture the valve, then there is a lot of embolic stuff that goes up towards the brain. And certainly MRI studies have shown that many patients, if you scan them at the time of TAVR, then you will see embolic events in the brain, but that doesn't always manifest as a clinical stroke. So lots of patients have these events in their head, but clinically look very well. And on the other side, there will be a patient that has a catastrophic event, which is clearly unwanted and not the target of our therapy, not the aim of our therapy. And so putting in a cerebral protection device is very attractive. And I've seen these devices being used, and I know that they are relatively easy to deploy. There are some nuances to them, and they do have some limitations in the fact that they don't protect both sets of supply into the brain. They only protect one side, which has a limitation. And in this particular study that was led by a colleague of yours, Professor Kapadia, took all comers who were having TAVI being placed, randomized them to one-to-one fashion, around 1,500 patients in each arm having either cerebral protection or not, and then essentially follow them up for a very short time. Okay, and that's because they wanted to see if there was a clinically meaningful stroke straight after the TAVI procedure. And they're only following up for 72 hours. And that is both a strength and a limitation of the study. But of course, if we believe that the stroke was caused by the implantation itself, then it's going to happen in that period. And what they showed was, unfortunately, the overall primary outcome of stroke before discharge or within 72 hours was no different, at 2.3% in the protected arm versus 2.9% in the control arm. So no difference at all. But as you alluded to, they had a number of secondary outcomes which they really emphasized in their final publication, and it led to a lot of controversy when it was presented at TCT, which was that disabling stroke was significantly reduced, with disabling stroke being about 0.5%, so very low in the protected arm, and 1.3% in the control arm. And there are some difficulties with that, because if we believe in study design and we believe in how we power these studies, then we have to go with the primary outcome rather than looking at the secondary outcomes. And the secondary outcomes are purely hypothesis generating, and they can't give us an answer, because that has a high risk of bias being added into the study, and really means that we're picking and choosing the outcomes that we feel happiest with after the fact. So I know that many operators who strongly believe in the technology were really disappointed with this study. And I think the principal thing to take away from this is that this is an area that remains unsettled. There still needs more work to be done. And that perhaps if operators feel very strongly about it, then we should be pursuing a larger study. Now, of course, that probably won't happen, because the industry partners basically want these studies to get approval for the device and to be able to start marketing the device. And once the device gets marketed and pushed out, then it's very hard to claw that back and to do a further larger study to see whether a study powered for disabling stroke would get the same answer or not. So that's where the controversy comes from. I know you feel quite strongly about this, Ankur. What are your thoughts?
Yes, no, first of all, excellent discussion and important study, really important addition to the literature. 3,000 patients, 40% were women. So, kudos to the investigators. And, I certainly have a soft spot for the study, because the PI, the primary investigator and the lead author is a colleague, a former colleague and a mentor of mine. And, I would agree. Hard to interpret, in light of what the primary outcome was in comparison with what the secondary outcomes showed. Stroke is a disabling, complication for any procedure for interventionalists, whether it's, TAVI or even PCI. Now in TAVI, the stroke rates have remained at 2.5%. And I'm talking about all comers TAVI. Now, certainly you have some subsets, particularly bicuspid patients or, even patients with valve and valve procedures in which, one tends to see stroke more often compared with just tricuspid senile calcific aortic valve stenosis. When I was at my former institution, where the principal investigator for the study is, it was routine practice to deploy these devices prior to every single case. So, I have my own biases based on how clinical practice was performed at that institution. That being said, we have to respect what the data show, and the data show that, the primary outcome was not different. Now, as you eloquently mentioned, the secondary outcomes, in light of how the trial was designed, are only hypothesis generating. And so, in the secondary outcomes, the disabling stroke was significantly less in the embolic protection arm compared with, the arm that did not receive embolic protection. So, I'm actually on the cusp, to be honest with you, after these data were presented. Well done study. The results were very, very heavily discussed, as we talked about it earlier. Does it change my own, practice? I would probably err on the side of saying no at this point. Although I'll be honest, I'm not as enthused about, deploying the device as I was prior to these data. That's just my honest, opinion, based on what the study showed. So if for any reason, the device is not going in smoothly, I would not think twice before aborting the procedure. And, the other big component of this is, and I think you alluded to it, is one is approval. And then second, in the US is reimbursement. So if based on these data in other hospitals, you're having issues in getting the device at an appropriate price and then having a hard time getting it reimbursed, then I'm not certain if the device will find, a market for itself. Yeah. Again, TAVI keeps expanding. It keeps expanding to patients who are younger. That is another important distinction here. The mean age was 79 in the protected TAVR trial. So, just being mindful that if you are doing a TAVI in a 65 or a 68-year-old, and God forbid that patient lands with a stroke, one would question if you had used this device, would the outcome be different? So, I remain on the fence. As a purist, certainly the data do not support routine use of the device. But I think it depends on the operator, your experience with the device, and then also the patient, and having these honest discussions with the patient. It has to be a shared decision. That's my take on it. I don't know what you think about that answer, Sukh.
Yeah, I think that summarizes a lot of very important things that come together whenever we're doing a procedure like this. We all have our inherent biases. It makes sense that if we protect the carotids, we can protect the brain and reduce the amount of stroke that can happen. And if we're experienced in doing it and it doesn't add anything in terms of risk to the patient, then why wouldn't we do it? However, when we do a study, we are aiming to try and prove one way or the other. And the study in a very pragmatic study, which brings in all comers, it will have a lot of pros and cons in relation to how that applies to the patient in front of you. Here, we've got genuine all comers in a cohort of patients that were appropriate and indicated for TAVI. So not young patients, but older patients. And so when we don't see that benefit, then it does put a pause on how we practice. But can you imagine the other side? If you've got a family member after a patient's now had a stroke and they go to their lawyers and say, well, there's this study out there that shows that the disabling stroke rate was dramatically reduced by the use of this product, then a lawyer can successfully argue, regardless of whether it was a primary or secondary outcome, because as far as I'm aware, that most judges are not informed on trial design or how to interpret these studies. It does put operators in a very, very difficult situation. And I can understand and I sympathize completely with those people who feel they don't want to change practice. It's very easy for those in academic practice to say, oh, no, the numbers don't lie. This is exactly what we're going to do and everything else can stop. But when you have a patient in front of you, it is genuinely very difficult. So I don't know. As I say, I'm not a TAVR operator. I take my the approach to the patient based on what my colleagues say. In our institution, we don't routinely use these unless there is a feeling that this patient's got very high risk or they've had multiple events before and we need to protect brain function as much as possible. I think that's how we tend to have selected use. But that has its own difficulties because, of course, if you only use it selectively, you're not going to be as good at using it. So that has its own issue. One other thing that we've become very interested in looking at is that there appears to be other mechanisms for stroke in TAVR, and some of that may well be the process of unsheathing the device itself seems to release bubbles and release some air that's trapped within the sheathing system itself, and that could be causing some of the event. And it doesn't matter, a sentinel device like this obviously wouldn't prevent those events. And I know that our particular institution is recruiting patients to looking at that, whether that has an impact on stroke. And I wonder what your thoughts are on something like that.
Yes, no, I think we've seen this beautiful demonstration, on Twitter, using a model where, as you're unsheathing the TAVI, device, so as you're unsheathing the valve, you are releasing bubbles into the vascular space. And could that be the cause for, disabling strokes in a subset of patients? As I discussed earlier on when we were discussing the trial, that, the stroke rate has remained at 2.5%. That's a number that we would like to see lower, particularly as, the indications to perform TAVI expand. And as we do more low-risk cases, and, as it even encroaches onto the moderate aortic stenosis space, the one thing that we would want is, a pristine clinical outcome with no stroke, So, I wouldn't just discount the device based on the expanding, base of patients and, even expanding indications, particularly in the moderate aortic stenosis space, as I discussed. And, I think the peri-procedural stroke field space needs to keep evolving for TAVI, because if the mechanism is completely different, then maybe we're barking up the wrong tree. So, important comment there, Sukh. And, it's going to be exciting to see how the field evolves, both in terms of preventing and mitigating stroke risk, and also, optimally managing these patients in the long term, whether we need to, anticoagulate them in the long term or, deploy antiplatelet strategy. That is a separate discussion in and of itself. And, we've published, several observational analyses in that regard. I'm referring to subvalvular, thrombosis and, subclinical valve thrombosis and also valve thrombosis when it comes to transcatheter aortic valve replacement. So, thank you. Watch this space for more, I would say, and just leave it at that for now. All right. So, that brings us to our last study that we want to talk about, on this episode. And, thanks to you for actually even bringing this to light for me, because I haven't seen the paper published, but really interesting data presented at the American Heart Association annual scientific sessions in Chicago in 2022. And this is a traditional Chinese medication. And please, I'm going to apologize if I'm butchering this name. It's Tongxing Lu. That's how it's spelled, at least. And you correct me if I'm wrong. So, and this drug was given in patients who were having ST elevation MI in China. And I'm going to have you talk more about not only the Chinese product, but also implications of these data when it comes to extrapolating these data to other parts of the world, and how do we garner new knowledge from data coming out from countries like China and India?
Yeah, thanks, Ankur. This is one of the reasons I picked this study. I think it's really opens interesting avenues for us to explore, and perhaps the study in itself is perhaps less important than perhaps the wider implications. Certainly, for me, it opened my eyes a little bit onto this whole space. And similarly, please forgive me if I mispronounce this. My Mandarin is not super strong. We had a great dinner in a fabulous Chinese restaurant the other day in London, in which we were accosted because it's Chinese New Year, and we were accosted by a wonderful dragon. And I realized that actually my ability to pronounce Chinese words is very poor with my Chinese friends, who laughed a lot at me. But this, as you say, is written as Tongxing Lu. And this is a natural product that's used widely in China, that was being studied for a number of years, that seems to have benefits in reducing no reflow. And we all know that patients with ST elevation myocardial infarction can have a syndrome of no reflow, in which the vessel is opened, we deploy the stent, the artery is opened, the lesion is relieved, and yet we may not normalize the flow in the vessel, because there is some form of microvascular damage and destruction within the microcirculation. There's microthrombi, there's blebbing, there's inflammation in the endothelial. And this natural product, which contains a whole number of different plant-based extracts, including ginseng and a number of other products, seems to reduce, in animal models at least, no reflow, and quite considerably so. And so it's in this Chinese study, of 3,700 patients across multiple hospitals in China. 124 hospitals, which in itself is a super impressive number. They recruited patients having ST elevation myocardial infarction, and they randomized them to have this investigational product and or placebo, and then simply looked at their outcomes at 30 days, which is a very reasonable point to look at if you're looking at an acute event, that in particular something like no reflow. And they found that there was a significant reduction in those patients who were given this investigational product, this Tongxinglo. And they found that around 64 patients, around 3.5% of the patients in this group had the events versus 99 patients, or 5.5% in the placebo group. And there was a reduction in a number of other secondary endpoints as well, including cardiac death. We wouldn't expect 30-day myocardial infarction rates to change, and sure enough, that wasn't the case. But there was perhaps a slight numerical reduction in stroke. So it raises some interesting questions. So what first thing it does is it suggests that whilst much of our focus here in the West has been on products that have been developed by the pharmaceutical industry, products that are conceived in a lab, and millions upon sometimes billions of dollars are spent on refining and identifying an investigational product, turning it into something that we then ingest and then investigating it. Here, there is a product that exists naturally, that exists for some time, that people in China have been using for many years, but just hasn't been looked at with the same kind of scientific rigor. And yet it seems to show benefit. So that's interesting in itself. And that one can imagine in many societies, as you say, in China and India, where there are lots and lots of traditional remedies that appear to have some benefit, perhaps we should be looking at those. And rather than, pumping all of the world's money into looking for a new molecule, perhaps we should just look at some of the things that we already have. And I think that's interesting in itself. And I always remember and think back on the fact that statins, although many of our patients will turn around and say, oh, I don't want to take this chemical. Statins were extracted from a natural product. Aspirin is extracted from a natural product. And digoxin, obviously, and many other do all come from natural products. So there's that avenue of things. And then the other component is, say, for example, there are many studies performed in China. They have huge numbers of patients, very huge numbers of patients having events like MI in incredibly phenomenal hospitals now with great facilities, incredible technical operators who achieve great results. Are these results now applicable also to the West? And I say that because for a long time, when we performed studies in the West, those hospitals in the Far East would sometimes say, well, that's great, but these data don't apply to us because our populations are different. In Japan and South Korea, for example, many operators would repeat the studies that had already been done in the West to show that they worked in a Chinese or a Japanese or a South Korean population. So do these studies therefore go back the other way? Do the findings in a Chinese population apply to a North American in the Midwest, for example? So that's important consideration to have. And then the final thing is, I think this really demonstrates a change in our conferences and a change in our academic discourse, that now important studies out of China, and I hope to see more studies from India, will start to take an important place, because I think this is the opening up of the world's knowledge, rather than us saying the words, saying that we're open, but not really being open. Actually incorporating studies that are from the Far East and putting them on the pedestal and really opening them up for a discussion and peer review, I think is a real benefit. And that's one of the other reasons I wanted to highlight this study, because it just opens our eyes a little bit to what else is going on in the world.
Yes, and also the world continues to be a melting pot, of cultures and ethnicities, and I'm sure you'll see patients in clinical practice in London who are, of Asian descent, and whether you would extrapolate these. Well, first of all, if this product would be available, for prescription in the UK, but you and I know, more importantly, when there are immigrants and even generational families who have roots in the Far East, there is a lot of travel and patients have access to these medications from their home countries. And then they would get you a bottle of this traditional Chinese medicine, and you'd be asked the question of, Dr. Nijjer, can I take this product? A study in China showed that there was a benefit.
Yeah, I think you're absolutely right there. So that we here in the West, we perhaps have our own biases, and we think, okay, are these results credible? Can we believe them? And do they apply to our patients? I think that these are all thoughts that go through our head. And I think it's important to the scientific community that we discuss these studies and we look at them and we do a deep dive and we look at the data, open the supplementary appendix, and to understand that a lot more. And I think it's important for us to spend the time and look at these things, because many of our patients are taking these supplements. I'm sure you are asked every single day, is it okay for me to take this supplement, doctor? And sometimes I look these things up and go, oh gosh, this supplement actually interacts with clopidogrel, or it interacts with warfarin, or whatever else the patient is taking. So you've got to be a little bit cautious. And recently there was a study, I don't immediately recall its name, but it was looking at some of these things like fish oils and various lipid supplements that patients often take, and they often take sometimes in lieu of taking a high quality statin. And we generally think of them as not harmful, but there was a study that's shown that actually some of them are bringing up your LDL-C levels. And so perhaps they are harmful. And so, it does behoove us for us to look at supplements, natural remedies, and not dismiss them out of hand, and to actually put them through a trial process.
Yes. Well, Sukh, thanks again for doing this for us. I know it's been a busy time for you, and we really appreciate you having us on, having you on Parallax, and having spent the time with us and discussing, as usual, in great length and detail and accuracy all these studies and what they mean for our patients in our practice. Any closing remarks?
Well, I'd just say it's great to speak to you, and I relish the opportunity to kind of go through some of these studies. Obviously, when we talk about them, sometimes it's easy for us to make mistakes or to misspeak on these kind of things, but we go through these studies in great detail, and I think it's more to try and take away some of the nuggets that can inform practice, because that's, after all, one of the reasons we do these studies, to look at how it informs practice, and trying to make sense of where these studies fit into our day-to-day practices is probably the hardest thing we do as physicians. And so, I just push for the audience to always take an opportunity to read the paper if you can, and discuss it, have journal clubs, and review these data in your local hospitals and practice groups, because there's a lot of value to have from doing that.
Yeah, I couldn't agree with you more. Thank you again, Sukh. And, for the listenership, please drop us a feedback. We take feedback seriously, and we try and incorporate our feedback in our future episodes. And we'll see you back another Monday.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/parallax. Thanks for listening.